So first of all, thank you to the organizing committee and to Robin and to Mark for having me here today. It's a pleasure to be here to speak to you and to tell you a little bit about myself, our association, and how we relate. I'll try to even bring that in as well. But first, let me tell you a little bit about myself, since I am here to give the patient perspective and not just the relationship experience between a cancer association and pharma. I was diagnosed with advanced colorectal cancer at the end of 1995, and the cancer had actually started in the colon and metastasized subsequently to my liver and to my lungs. Now, in 1995, you might remember that there was very little on the market in Canada, or indeed worldwide, in terms of therapies. 5-FU was about the only drug available, and they were debating whether or not to use it in combination with leucovorin or levamisole. And that was the big debate of the day. Today, we have a buffet of products available, all sorts of treatments, including small molecules and anti-VEGFs and EGFR receptors, all different types of few chemotherapies which were not on the market at the time. If you recall, irinotecan was developed in this interim period, and aloxatin or oxaliplatin was developed, but this did not exist in 1995. And in fact, the situation in terms of delivery of healthcare was a problem as well, since OR time was difficult to find, and people were actually treating patients with stage 4 colorectal cancer as people who should just go and write their will. But as an attorney, I'd already written my will, so I had other things to do. I was 41 at the time. As I said, an attorney. I am married. I had 3 young children at the time, and this is 18 years ago. And I was really wondering, am I going to see my daughters get married or my son's bar mitzvah? What would happen during the ensuing years when people were telling me, you have, if we can remove it from your liver, approximately maybe less than 5 years to live. So that was really not a very exciting story for me, and one when I was told originally, I literally fainted on the floor. And while that was probably the weakest moment of my time, when I got up from the floor, it was the strongest point in my life, because that's when I decided I would fight. And that, I think, is what made the difference. But I had no idea what cancer was. I had no idea how it came, how it could be prevented. And in fact, the only reason why I knew that I had to check something was because from time to time I had what my doctors thought was a hemorrhoid, some blood in my stool. And I put that off for a time. Well, getting access to treatment in that stage was not very easy. And in fact, as I said, there were some problems with OR time, getting the right treatments available in Canada. I did my research worldwide to see what was available, and ultimately, not as a result of my research, but as and visiting physicians in the United States and trying to find the latest and the newest, what to do, cryosurgery at the time, hepatic arterial infusion, and so forth, I decided, given the odds that they had given me, to go back to Montreal and be operated. And it was only as a result of having been sent home 3 times and not being operated in time that I had no choice but to go to the United States for my surgeries. So as fate would have it, that's what actually got me through. And after doing hepatic arterial infusion, something that we're now starting at Sunnybrook here through one of our trials or studies, and having cryosurgery, now replaced by radiofrequency ablation, which was state-of-the-art at the time, and starting with some of these therapies, having multiple resurgeries on the liver, subsequently on the lungs, in addition to the colon, of course, and doing a vaccine treatment out in LA for a while, that actually I've been free of disease for the last 9 years or so. So, I forgot to say one very important thing. Can this go back? So at the time, not only did I wonder what was going to happen with my own children, but I didn't know that finally, 18 years later, I'd be a grandfather and have a 1-year-old. So that's little Oliver. So who are we as an association? We are Canada's patient voice, nationally recognized patient voice for patients with colorectal cancer, of course. And colon cancer and rectal cancer are seen together. That's why it's so hard to say, colorectal, but it's the colon and the rectal, the large intestine, which we deal with principally. And we incorporated in 1999, but were founded in 1998 with the help of Dr. Tony Fields in Edmonton. Some of you may remember him from the NCIC, and Jean Maroon from Ottawa, both oncologists. And we are a not-for-profit charity working right across the country. And we partner with everybody and anybody, from the patient to the Minister of Health. We work with government, healthcare professionals of all sorts, and I'll tell you a little bit about that. Of course, pharma, cancer agencies, other not-for-profits, citizens versus patients or users. Very important to know the difference these days, especially when determining budgets. And patients who are all committed together with us to building a healthier country. As an association, we do three things: awareness and education, support for patients and their families, and advocacy. And I'll talk a little bit more on advocacy than the other things today, but our advocacy program is also divided into three basic areas. Primary prevention, something you'll hear a tremendous amount now, not only because it's cost effective, but it really is a great idea to prevent not only colon cancer, but many other diseases through healthy lifestyles. Diet and exercise will be coming out of our ears. Colorectal cancer screening programs, you may be familiar, for example, in Ontario, Colon Cancer Check. Well, we worked with governments right across the country in starting about 2005, but really focused in 2007, and today every province is bringing in, or has already brought in, a colorectal cancer screening program targeted to the 50 to 74 population with either a fecal occult blood test or now, more appropriately, fecal immunochemical testing. And lastly, equal and timely access to effective treatments to improve patient outcomes. And each one of those words means something. And we've worked hard over the years to understand what that means. But equal and timely, we'll get to in a second. Effective is where you guys are at, for the most part, hopefully. And improving patient outcomes is really the bottom line. No pun intended there. Awareness and education. What do we do in awareness? We have a multitude of things we do. We utilize every single thing that we can do. And those of you in the communication may know us well. We have our big 40-foot giant colons traversing the country. You can walk through the multimedia experience. And they make a big hit when we put the minister in front of the asshole. It's just fantastic. Great experience. And couldn't get Mayor Hazel to do that, though. She was too smart. Through our bilingual websites, web banners, Facebook, blogs, those of you who are following me on Twitter or LinkedIn, you'll see the numerous articles and tweets that I do now, daily myself. YouTube commercials, we have a fantastic series of commercials that we've done and a new one just out now. Radio, print, tabletop displays. We're at all the big oncology exhibitions, ASCO GI, back of buses even from time to time, or in washrooms, conferences and corporate events. So we will do everything. We will stop at nothing to get people to know that colorectal cancer is the second biggest cancer killer in the country. It touches over 23,000 men and women in this country every year, and about 9,200 people this past year died from it, and much of that could have been prevented. Education is not only for the public and the patients, knowing about the signs and the symptoms and the treatments, but also for health professionals. And we put together multidisciplinary consensus meetings and publish on areas such as hepatic arterial infusion, hypothermic intraperitoneal chemotherapy, early stage rectal cancer, treatment algorithms for advanced colorectal cancer, hereditary registries, reimbursement on ostomy supplies, personalized medicine, and so on and so forth. And we advocate on these consensus statements that we put together. Just a couple of pictures. You can see our giant colon from above, some of our bus campaigns, our getyourbutseen.ca campaign, and our new Facebook application, which I urge you to get. And basically, by accepting that, your friends, 1 in 14 Canadians will be diagnosed with colorectal cancer, and when you accept it on Facebook, 14 of your friends will be populated in those frames, and you can continually send the message out to get screened. So on support, what do we do? Well, we've got a number of things. We offer psychosocial support. My original support that I received was in New York through Gilda's Club, and we hope to get that going in Canada at one point. But now we've branched out into working with all the health community and wellness centers across the country. And we provide a reliable source of information, and you can see much of that on our website, but we also have hard copy as well, and with your help, we can even build that further and get that distribution going. We receive over 17,000 hits a month, and much of it is to obtain the important patient information. We have developed a cancer coach program where we have about 50 peer-to-peer people working in peer-to-peer support across the country. These are patients and family members, apart from our professional staff who answer patient questions, set up support groups, and do a little bit here in Toronto, patient accompaniment. But most importantly, we have toll-free numbers where people can reach us and communicate with us online. So getting back to the advocacy issues, which I think is of paramount importance, and understanding that patients actually have to fight for the standard of care due to variances for various reasons, mostly in timing and drug approval and reimbursement across the country. So you guys create the drugs, but people have a hell of a time trying to get access to them. And this is for various reasons. One, because of the constitutional relationship. We know that within our Constitution, the provinces deliver the services, deliver the drugs, and reimburse on a provincial basis. And this really causes a lot of headaches, especially for people who are the uninitiated, who think we have one Medicare system throughout this country, and that's all you have to do, and we're covered across the country. Well, not so simple. We have, obviously, each province has their own formulary for which they pay for drugs, and that varies from province to province. We have issues dealing with oral therapy versus infusional therapy reimbursement, for example, in Ontario. And one of our patients, you may have read about recently in the newspaper here, had a huge time trying to access an oral therapy and third-line treatment, even though other third-line treatments, which would have been in the $40,000, $50,000 to access, which he wasn't qualified for because he had KRAS, he had the KRAS mutation, and he couldn't get this simple, not so inexpensive, but relatively cheap product in third-line therapy until he screamed and shouted in the media, contacted the pharma company, got in touch with me, and ultimately he's getting it. But why should we distinguish oral chemotherapies, for example, versus infusional ones when it comes to patient access? It makes no sense for various reasons, and we can get into that at another time, but even quality control and who's delivering these medications and so forth. So important when we talk about chemotherapy. But also we have variances across the country in terms of the lines of therapy, and access to certain drugs may be available in one line of therapy in one province and not in another. And these are huge, huge issues for patients who are just trying to get the standard of care. So our approach in dealing with this is really different now. Then, as I say, up until most recently, we had great campaigns. We would have letter writing campaigns and email campaigns, and we would flood ministers' offices, and we would have press conferences and do legislative breakfasts and do everything that we could do to persuade from a political point of view, access to treatment. And that's not completely outdated yet, but as you know, there are laws, for example, in Ontario, which prohibit ministers from intervening in the decision-making process, which is kind of ridiculous, since ultimately these are the people that actually have to sign off. But this is now being delegated down the line, and it's become more of a bureaucratic decision, making it very hard and challenging to influence from a patient point of view. So that is the so-called old approach. The new approach is much more technical. The Pan-Canadian Drug Oncology Review has been set up, sort of a branch of the CDR, if you will, in order to deal with access issues and evaluation of not only in the efficacy, but of the cost-effectiveness of various drugs, and making recommendations to the provincial bodies, whether, with the exception of Quebec, whether or not to reimburse a certain drug. And this can be done simultaneously and even before an NOC is made at Health Canada. So very interesting. There are certain delays, as we know, and that's a big issue that we have to deal with. For example, drugs are approved in the United States, and patients are just waiting for them here. Until we get either a special access or until an NOC is filed, that's a problem for patients in this country. So the Pan-Canadian Drug Oncology Review, or PCODR as we call it, has been set up as an intra-provincial body in order to try to deal with some of these issues and get more of a national consensus on it. Unfortunately, the province don't necessarily have to accept, although they're supposed to, but they don't have to accept the decision of PCODR, and we do have still variances. So this is a new process, and I could tell you that it's quite complicated. And as a patient group, we are an accredited body. We have to become accredited with PCODR and file a very detailed type of submission with display all our conflict of interest. So if you're helping us, we got to tell them. But we cannot get any help on putting the application together. So it's really a true and pure patient input into whether or not a drug should be approved by PCODR. And we'll see what happens, but we just filed one yesterday, literally, on regorafenib, and we'll see what happens with respect to that. In Quebec, it's an entire different dog's breakfast. And there really isn't very much way for patients to have access, and that's one of our big things to work on for this year. But I can tell you that when it comes to oncology drugs, there's not even an oncologist that sits on the board that decides whether or not this oncology drug should be approved, although finally this year there is a separate body which of oncologists which can provide input. But they seem to have a philosophy in Quebec that approval of drugs and being a patient is a conflict of interest. So we're going to be working on that. So with that, I want to tell you that colorectal cancer is a disease that is preventable, treatable, and beatable. And we look forward to every opportunity to working together on either our awareness and our educational campaigns, support for patients, or on any of our advocacy campaigns together with you. So please feel free to join us. There's our toll-free number on our website, and you can call me, you can follow our tweets, and LinkedIn, and do all our Facebook apps, and have some fun with that. But the most important thing is that you do communicate with us if you ever feel that you want to. So thank you.